Hello everyone and welcome back to IPC in Action, our Infection Prevention and Control podcast. It's been a little bit of a hiatus for me, but I have brought, I should probably introduce myself first. I'm Fran, one of the infection control nurses, and I have brought two very special guests with me today who are brand new to podcasting, so I will let them introduce themselves. So,
hello, I'm Shincy Abraham, one of the IPC and work across the site, Gloucester and Cheltenham.
Hi, I'm Geraldine. I'm one of the infection control nurses working across both sites as well. Thanks for that nice Fran, special guest. I feel honoured.
Well, I do have very special guests with me. So we're going to be going over a very important topic that we know that you hear a lot about on a day-to-day basis as we get to this time, but we are going to be talking about today how you can win this winter, which is a great name Jer came up with. Love it. So we're just going to be going through some of the organisms you'll expect to see, which include respiratory, DMV, etc. So we'll just be talking about what's the most important steps to be taking this winter to protect yourselves and to protect the patients. So our first point will be introduced by Jeff for our topic.
So there's three key main points. I'm starting off with early identification. So it's recognising the signs and symptoms of those respiratory viruses you'll see this winter, and also other bugs are available. So things like norovirus as well. Recognising them and the patients as well as staff, those symptoms. So as soon as you identify that there's an issue, then that's the time you need to act. There's two other key points, which is prompt isolation and then clear communication. So I think Shincy is going to do the prompt isolation.
So isolate them appropriately. If you have any patients with respiratory symptoms, make sure you isolate them immediately and make sure they are swabbed if according to the criteria. Like COVID, you may have to ask the clinical team to assess them if they meet the criteria for treatment, then sample or any other respiratory virus if you are suspected, just isolate and do the swabbing as appropriately. Like you could send respiratory PCR if you're not sure about COVID or flu or any other respiratory illness, because we have this RSV and all other rhinovirus, lots of different respiratory viruses.
Mm-hmm. Yeah, it's all very important, yeah. I think, all of these points really. And our final sort of main big point, our overarching points is clear communication. A lot of the time, I think you guys will agree that we don't always get told about specific patients that may be symptomatic or a group of patients that may be symptomatic. So sometimes it's difficult to identify where there might be an outbreak starting. So clear communication involves just giving us a ring, letting us know that you've got a couple of patients you might be worried about. Letting site know as well is very important in terms of bed movements and bed flow. And also speaking to each other. A lot of the time as well, there is a miscommunication between staff members, like if somebody took a swab for a respiratory swab on a night shift and it wasn't handed over to the next day, we get the result through and then the staff aren't aware that a swab has been taken or that the patient's symptomatic. Same with stool samples for norovirus, all of those sorts of things. So clear communication with the infection control team, site and each other, most importantly, and other wards as well. Mm-hmm. So we're going to take slightly more of a deep dive into each kind of organism. So we have our main group of sort of respiratory viruses that we'll cover, which obviously includes COVID-19, influenza A and B, and RSV. So we'll go through topics in each to watch out for, what we need to identify and do for all of those. So if we were starting off with the symptoms, I mean, Jer, what sort of symptoms might you see with, say, COVID, flu and RSV?
Yeah, so the symptoms are really similar these days. So the classic COVID symptoms of years gone by, lack of taste, that's not seen so often these days. The symptoms generally are quite mild. They mostly will include a temperature, so a pyrexia. also with a new cough potentially. Knowing if they've had previous exposure to COVID or flu is really key as well. So if they've got known exposure to an organism and then they develop a new cough, for example, and pyrexia, then you're more likely to be suspicious of that particular organism. The good test at this time of year that we can, when we're just at the start of flu season, is to do that Gene Expert 4. It's a 4-in-1, so you get your 2 types of flu, and you get your COVID, and you get your RSV in it as well. And it's difficult when you've got similar symptoms for them all. I think the management of them all is quite similar. So again, it's the prompt isolation. It's recognising if there's multiple cases in the bay, because what we're trying to do with all our actions is to try and minimise transmission between patients and to stop an outbreak happening at the very early stages, so nipping it in the bud at the earliest point in time. And when you do that, when you stop an outbreak from happening, it has it stops the outbreak for prolonging over a longer period. It, if you get the patients isolated promptly, it stops the bays closing, hopefully, and then visiting won't be affected. The other patients who are obviously vulnerable could be in hospital a bit longer if they do develop it. So it's all about that containment. That's our key aim, really.
So again, very similar in terms of what you're needing to do for precautions. So as a starter, something that we notice a lot of the time people aren't is fit tested, and fit testing is a legal requirement. If you're working in healthcare, there is a chance that everybody could be seeing somebody with any respiratory virus, or even things like tuberculosis, measles, etc., where you would need to wear an FFP3 respirator. So as a starter offer, FFP3 respirators are very important, and they should be worn for all of those respiratory viruses. If, for example, you were going into a room and there was an AGP being performed, or somebody had a really kind of violent cough, lots of spluttering, then you would sort of risk assess and consider wearing a visor as well, and also considering wearing gloves and aprons for that direct contact with the patient and their surroundings. And I think, just with some of the more important points with PPE is taking it off in the correct order as well. So the donning and doffing. And we're hoping that everywhere has donning and doffing posters, sort of just to explain it all. So the most important points are remembering to take your apron and gloves off when you're inside the room. Hand hygiene, come out of the room, dispose of your mask, visor, and hand hygiene again. Remembering that hand gel will be sufficient, but if you have visibly soiled hands, obviously washing your hands with soap and water, and not wearing those masks in between bays or the PPE, because it can be spread that way, it's kind of hard to imagine, I think, when you are kind of actually picturing it, but it's a possibility for sure. So that kind of covers the PPE for the respiratory.
The only thing I would potentially add is when you're taking your mask off, take it off with the straps over your head and drop it into the clinical waste bin. When staff have been known, certainly, I don't know if anybody remembers Ebola, but the point in time when people have become infected with organisms is having those hands on their masks. So that's the risk, that's one of the risky points, is taking that mask off without touching the front of the mask, and then absolutely gelling your hands is key to reducing the risk of transmission.
100%. And again, another important point which Jara's touched on and Shincy's spoken about earlier with isolation is, what are the time frames that you would kind of isolate patients for?
So the isolation, from the beginning of the symptoms until at least 5 days, or until they are asymptomatic with all the symptoms, and at least 48 hours free of any temperature. That's the criteria for isolation. And if you have any doubt with the isolation process, always you can contact the infection control nurses.
And then we also have some different criteria as well for haematology, oncology patients, those who are a bit more vulnerable. So, Jeb, what are those
Yeah, so the patients that are immunocompromised are those from DCC, follow a separate action card. It's action card, I think it's 91. And it's patients with who are immunocompromised hang on to the virus longer. So they have to be isolated for 14 days and re-swabbed at day 15. And if you look at that action card, if at day 15 and they've got no symptoms and they've got a negative swab, then they're stood down and stepped down, and they can be moved out of that side room and moved into kind of what it used to be called the green pathway, but I think the pathways have nearly gone now. But they can certainly come out of that side room into the bay. Again, contact us if there's any kind of and you're not sure what to do. But the action cards are still on the intranet. If you type in COVID action cards, I think the quick link is gone. Yeah. But if you type it in, you will find it.
Yeah, it will come up. We have got a whole range of action cards still available. And that was actually kind of one of the points going on to next, is that when we're talking about testing and treatment, there are some guidelines in terms of what's appropriate and what's not appropriate. So, I mean, for example, with testing, the action card effectively states that any person that has any respiratory symptoms, if they are eligible for COVID antiviral treatment, which is included in Action Card 1 on the intranet, they would be eligible to have a COVID test. And again, as Gerald and Shincy have mentioned earlier, we were talking about isolation, and that's probably the most important part of all of it before you get to any testing. Again, we see a lot of people that have been tested and not necessarily a consideration for isolation, but it should be the other way around, really. And we're very much aware that that's not always the easiest thing to do. So we're always, obviously our phone lines are always open. Our phone lines are always open for you to discuss with us. That is absolutely fine. If there is a kind of wider concern and the clinical team want to discuss with anyone, they're more than welcome to contact microbiologists as well to run through it with them too. So, I mean, for treatment for COVID, obviously the antivirals, some of the conditions that may be included in those that would be eligible for it might be things like if somebody has an autoimmune disease.
The oncology, hematology patients usually meet the criteria, and also the patients who've had transplants in the past. Yeah. So those are the kind of level of immunocompromisation that meet criteria. And if you click on the action card, there's a QR code still on there, isn't it? And the clinical teams are really good. They can always liaise with the respiratory team, who are hot on knowing who needs treatment or not. Yeah. Different organisms have different viewpoints. I know you've mentioned COVID at this time, Fran, about the treatment and of those. With flu, most patients will receive a treatment dose. If you're the patient with flu, you will receive a treatment dose. But those exposed patients for flu should be offered a prophylactic dose of Tamiflu if they meet criteria. I think that seems mostly the patients will have that. I think it's just based over your age and comorbidities.
Exactly, yeah. And I think the guidelines for that are on Microguide. And again, if you type that into the intranet, then there'll be a link to Microguide and who is sort of appropriate for that treatment. And again, just based on their complexity is a important point for the clinical team to assess.
The other organism we see is RSV. So RSV is more seen really in children and vulnerable adults. There is a vaccination. This is the first year there's a rollout nationally of a RSV vaccine. So we're hoping we'll see less RSV in the trust, and certainly regionally, nationally. There isn't any treatment for RSV. It's symptom control, and again, making sure it's contained. So symptom control. You know, your usual paracetamol, keeping people comfortable, fluid hydrated. Yeah, exactly. Nothing. It's not like rocket science, but it's back to your basics, back to your basic patient care.
Absolutely. And moving on from vaccinations as well, obviously we would encourage everybody possible to get their COVID and flu vaccinations. So they are available to book if you go onto the intranet. and they're being done either in Redwood or just outside the old cardiac ward in Cheltenham, and they also have a roving team as well, so please do get in contact with them, and you get a lovely badge at the end, which is very nice.
And you know what, they're doing patients as well.
Yeah.
So they mentioned that today, and it's really useful because a lot of the patients, if they're admitted, will miss their slot with their GP, so it's a good time for them to catch up if they're if you know you've got an inpatient in that are needing their vaccine.
Yeah. And then finally, I mean, Shincy, do you want to tell us about cleaning? What's required for cleaning for respiratory viruses?
So it is an amber cleaning with a cut and change of the bed space, or if the patient isolated, then that room need amber cleaning with cut and change. That's the cleaning criteria.
And making sure to clean all of the
equipments, with the clean wipes.
Single-use equipment for patients as well is important.
Well, that's I think we've covered up the respiratory viruses. There are other viruses like whooping cough and other things, but I think we'll just stick with those ones. I think they're the main ones.
The winter ones.
Yeah.
So
norovirus.
Norovirus. Everyone's favourite bug, the winter vomiting bug, although we did have it in the summer, which was unusual. So I'm sure everyone's got the hang of it by now, and as much as we don't want to see it come back, there is definitely a likelihood that it can, so we just want to be prepared in that respect. So, symptoms of norovirus, what have we got, guys?
Well, norovirus, it's the nausea, vomiting, diarrhea. I think the projectile vomit is usually the first thing, and then usually you'll get the diarrhea later. The elderly don't tend to do so much of the vomiting per se. They have that they're not such an acute immune response, so you will see maybe diarrhea with them. Usually we get told when there's at least 2 patients in the bay that have it. So knowing your patient, if they have a sudden onset diarrhea, sudden onset, kind of unexpected, and the patients have other symptoms like headache, aching limbs, high temp. So it's that kind of, I think they used to call it gastric flu, didn't they?
Yeah.
So it's those kind of symptoms. Try and get that first patient isolated before it goes through the bay. Quite often our management as infection control nurses differs when you've got those multiple cases in the bay. Norovirus is very spready, so you just need 10 virons, and if you think that you vomit and there's millions of virons kind of airlised at that moment in time, and you need 10 to pick up norovirus, it is really, really spready.
It's crazy. The way that we've seen it spread through wards has been pretty dramatic, I would say. And I think a lot of the time we forget about, especially with elderly patients, if they are vomiting, sometimes the force that it takes some people to vomit and constant diarrhea, it's exhausting for anyone that's had it. So I think it's important for us to try and protect them from it as much as we can.
Absolutely.
And also with visiting as well, we've got posters up around the hospital encouraging people having any of those symptoms as well not to visit, because we don't want it to be spread round. Yeah,
previous outbreaks have been linked to visitors.
Absolutely.
And it's the time of year, it's just reminded them not to come in and not to visit.
Definitely.
I think with norovirus, it's all about symptom control, isn't it, for the patients, and that fluid hydration, and it is usually self-resolving within about 1 to 2 days, but can be a bit longer sometimes.
Definitely. So in terms of the precautions, what we're trying to do, obviously, to stop the spread and transmission, I mean, what sort of things do we do in terms of PPE? Well, just general precautions, really.
So gloves and apron should be worn if you are caring for a patient with the norovirus, and you need to assess the need for surgical face mask. If they are vomiting, then definitely wear the surgical face mask because it's aerosol, and remove the PPE before you come out from that patient area or patient room, and make sure you wash your hands with the soap and water, which is really important. Cleaning all the equipments with the red Clenil wipes is also really important. And as Fran mentioned earlier, try and use the single-use equipments for these kind of patients.
Definitely.
Because cleaning is sometimes it is not, thorough cleaning is not been happening always.
Yeah, definitely. And it's, I think, just the thought of, so with the surgical mask and vomiting, just the fact that the sort of particles from vomiting can actually remain in the air and in the environment for a decent amount of time. I couldn't say what it is in hours or minutes exactly, but the thought of that would make... I prefer to wear a surgical mask in that instance, so they are encouraged, but it's not mandatory to wear one, but we would encourage you to wear them, definitely. In terms of testing and what we need to do when we're starting to identify one of these outbreaks and what you can do. So we kind of start off by suggesting that if you have patients that you're concerned about starting to have DMV-like symptoms, that you start up a monitoring sheet, which includes their name, their bed space, and documenting diarrhea episodes, vomiting episodes, etc. And this will really help us from an infection control point of view.
And you know what's really important is sending those stool samples, because when the stool samples get sent to the lab, it does require usually the trigger of the infection control nurse or the infection control doctor or the microbiologist to get those samples tested. The lab do like to do quite a few at the same time. So it's really important to get as many stool samples as possible down to the lab, and then we can do a batch run. The lab will say the testing isn't for diagnostic purposes. It's really to determine whether there's an outbreak or not. And once we've got one or two or a couple of those positive results, the expectation is if we've got more patients with DMV on that ward, that it is going to be norovirus. It's kind of that spready.
Absolutely. So it's really important to identify these things ASAP so we kind of know what we're working with, because there is always the likelihood that it could be something else entirely. So we just want to know as soon as possible so we can help you manage and help you out as staff to prevent it spreading any further.
And you know what as well, it's really important to ask those questions when you have patients coming in from either ED or from other areas. Is the acute trust does see norovirus and other outbreaks, but when they're coming in from care homes or other hospitals, asking that question at handover: have they been exposed to? Is there anybody else in the care home with those symptoms? Is there anyone else that they've had exposure to, whether it's in their own home, and making sure at that point trying to isolate them and find them in the bed at that time. So it's twofold really, having the right questions at the start when patients come in, and then transferring them with the right information as well.
So taking those preemptive actions to stop it in its tracks effectively, to break that chain of infection, is really important. So you'll hear us saying breaking the chain of infection a lot. So in terms of isolation and timings as well, so as Jer said, try and isolate them as soon as possible. There may be an instance where if we're managing a whole ward that has norovirus, that we may have to cohort some patients together based on their symptoms. Obviously, we're aware of the impact of movements on patients. It can be stressful for them, confusing, and can have a psychological impact. So we will try and minimise this as much as possible. But we equally have to think about bed flow, trying to get a ward open again, and making sure other patients are able to be admitted as well. So we usually say with norovirus that the patient, after they've been isolated, needs to be free of symptoms for 48 hours before they can be stepped down out of isolation. And in terms of ward closures as well, we would always say that the ward needs to have not had a new case of DMV for 72 hours before we can reopen the ward. So those are sort of the isolation priorities.
The infection control nurses do review those wards daily, and quite often going into winter we'll have an on-call presence over the weekends just to facilitate the site team with their ward openings and bay openings. I think.
Yeah. But all of that information there is a norovirus toolkit online, which is really helpful, gives you all of this information and more, and the DMV monitoring sheets as well. So I suppose our final point for norovirus is the cleaning. And, basically the clean is that you need to have an amber clean of the room. And again, as Shincy was saying earlier, curtain change as well, because we're thinking about those particles from vomiting. Again, single-use equipment, cleaning commodes with red wipes, as we should be doing with every single commode, regardless of whether there is DMV or not. Mm-hmm.
The other thing with norovirus is that the staff quite often go down with it. So it's absolutely key that staff don't come to work until they've been 48 hours clear. And, we do separate the staff from those staff that have worked in those bays that have got that are closed with norovirus, for example, still. We do like to have that separation between staff and staff looking after the patients who've got symptoms and staff who don't. So that also is another kind of tool in our toolbox to try and stop the spread between the bays.
Exactly.
There are checklists, aren't they, Fran, for norovirus and COVID.
Yes,
so where do we find those, Fran?
So when an outbreak starts of either of those things, then we will send a start of shift checklist to the area, or you can request it from us as well, and that just makes sure that everything's in place for the day, protecting yourselves and the patients as well. So that was a big old round off of our some of our not main necessarily, but main things that we may see during the winter. And in Jer's words, we are really wanting you to win this winter and be safe and protect yourselves and protect others as well, but also looking after yourselves, and your health and safety and your well-being is really important. So, top tips. What have we got for our top tips for winter preparedness?
I think my number one top tip would be to isolate. Isolate. It's tricky though, because there are a limited number of side rooms, and we are really mindful that infection control, obviously we're wanting everybody isolated where we can, but their side rooms are used for other cases. But I think the main top tip for a ward coordinator would be know who's in your side room, know why they're in the side room, know when they can come out of the side room, and what clean that the side room is needed to have to put that side room back into play. And I think if you know that, then it makes it a bit easier when the site team come round, or when we come round and say, this is what needs to happen to make that, to isolate those patients. And the other top trumps for for side rooms is that there are some organisms potentially, obviously we would want you to isolate, but say, for example, MRSA patients, if they've had a couple of days of topical suppression, maybe we could move those patients out. We would want the airborne viruses to be isolated as a priority, also patients with diarrhea as a priority. And then there may be some risk assessment and negotiation that we can help with to kind of step down those other patients. So that's my top tip anyway.
If you're ever unsure about those things, please let us know, and we're more than happy to help. I think my top tip, if you don't mind me going on to it next, Shincy, or I'll cover. I think there's only one more. Well, I wouldn't say one more top tip, but a sort of a round off of all of those. Is the communication is so important. We need to know about these things. That's what we're here for. That is a big part of our role. So we need to know about that, as do sites, so we can help to assess and also to manage it as early on as possible to try and prevent it from going any further. And our final biggest one from the infection control team, as always, hand hygiene, PPE. Obviously, you heard us talking about it a lot, but that's because of how important it really is. It stops to spread those viruses. So we want to use that effectively, and hand hygiene It's the very best thing you can do.
And is it too late to mention fit testing as well?
No, go for it.
Fit testing, we can support with that. If you're finding that you haven't got fit testers on your ward, I can come and sign off a competency for your fit testers. And there's another IPCN, one of our colleagues, Kath Pitts, has done that on several wards already. Mm-hmm. A lot of wards are really good, and but some wards have a lot of new staff coming at the kind of all at once. So it's really key now to have your staff fit tested with the models of FFP3 respirators that we have available. Mm-hmm. There is a new easy mask that apparently lots of people pass on.
That's very good.
So if you've got those new staff with the little faces, then those are the masks I would say try first, because they're supplied now by the trust. Mm-hmm. So go with those first, I think.
Yeah, absolutely. So a lot of information to take in there, and as I've said, we're very happy to clarify anything if there are any questions. So, as usual, if you have any questions at all, don't hesitate to contact us. So we work Monday to Friday, 8:30 to 4:30, and weekends, but that will be evident when the time comes. So our extension numbers are 6122 for Gloucester and 3129 for Cheltenham. Our group email address is in the address book. And I want to thank my two colleagues for joining me on this podcast. And
it's a pleasure.
Talking about the most important, one of the most important things we can do. So we will see you next time. Bye.
Bye.